Hello, my name is Dana Koltar, and I'm with Healthcare for All Minnesota. I'm your host for today's webinar, which is the second in a series of 3 webinars. This one is on the U.S. healthcare system is broken, fix it with Medicare for All, specifically Medicare for All, how do we pay for it, which is a video provided by the Fix It Healthcare at the Tipping Point organization, and features Dr. Gerald Friedman. So today, our program will consist of a set of slides, then the 12-minute video, then some additional slides, a Q&A, and a call to action. Our presenter today is Ann Jones. If we can go to the next slide, Ann. She is Vice Chair of Healthcare for All Minnesota and a retired RN, and she will be presenting the slides. And let's see, I also wanted to mention that our third webinar, which will be Canadian Healthcare, Debunking the Myths, that will be on August 5th. So, Ann, I'm going to bring it over to you if you want to get started on the presentation.
Introduction also. I'd like to welcome you for the second set of in our series. I think that you'll get some information that might be new to you and might be helpful and will inspire you to get involved in helping us fix this. One of the most challenging situations for advocates of a single payer Medicare for All system of financing healthcare is that conversation in which somebody says to you, well, okay, I agree that everyone should have healthcare, but how are you going to pay for it? And you really wish you had that snappy one-liner that just nails it. Well, today we're going to try to give you enough information that you can come up with a simple, straightforward response that helps you have that conversation on your own terms. So I've been involved in patient care for over 50 years, but I learned a lot along the way about how our system does or does not work for those it is supposed to serve. I now spend my time volunteering for Healthcare for All Minnesota to change and fix how we pay for healthcare in the United States, starting right here in our state. I want to talk a little bit about our current system before we actually take a look at the video and take us back to before the onset of this COVID-19 crisis to remind us all that if we don't fix the whole system, we will go right back to the problems we've been having for decades with cost, quality, and access to healthcare. We are part of, at Healthcare for All Minnesota, is collaborating closely with other organizations like Physicians for a National Health Program and the Minnesota Nurses Association, as well as a number of other advocacy groups, including advocates for farmers, for small business owners, and so on, all working on reform. I really believe that our challenge isn't to prove that we need a better system of paying for healthcare, but to build the political will for real change. It's important to remember that even before this public health crisis hit, the underlying conditions that precipitated it are still there. And keep in mind that these conditions existed during a period of historically low unemployment. If we change nothing, this will persist and possibly worsen, since no one can really predict when we will return to pre-pandemic employment levels. You will hear opponents of change claim that we have the best healthcare system in the world. And if that's true, how is it that so many people can't get the care they need, most often because of cost? And why are we the only developed country in the world that ties insurance coverage to a job, which is really a holdover of World War II economics, despite the high cost and insecurity of employment-based coverage as a model. Now, then layer on this pandemic, rising unemployment, and our reliance on employer-sponsored insurance. Millions of Americans are losing not only their incomes, but their health care coverage. So now more than ever, the folly of tying health care coverage to a job should be becoming quite obvious. Health insurance linked to a job means being one diagnosis or one job loss away from financial ruin. And the remedies suggested so far, reopening the exchanges for purchasing insurance, taxpayer subsidies for COBRA, for example, are complicated, expensive, and short-term. The irony here, of course, is losing health insurance in the middle of a deadly pandemic. So just by the numbers, we have a system that costs too much, does too little, and leaves too many people out. At $3.7 trillion in total health spending, the healthcare industry currently consumes almost 18% of GDP, or 1/6 of an $18 trillion economy. If we do nothing, total health spending in the U.S. is projected to go to $4.3 trillion by 2023 and $5.9 trillion by 2027. Health spending here in Minnesota is projected to double over the next 10 years. And of course, these numbers do not account for the cost of managing the COVID-19 pandemic. A little visual that shows where we land in comparison to other developed countries. It shows that health spending per capita in the US is 2 to 3 times as much as in other developed countries around the world. And you might ask, what are we getting for this money? Not as much as you would think. The US ranks 37th overall in health outcomes. We experience higher rates of chronic disease, and we rank last or near last in access, efficiency, and equity of our system. It's important not to confuse health insurance with health and health care. The overall health of a population depends on social and economic factors that many of us take for granted, but that we could do a better job of providing to everyone in our society. So what I just want to draw your attention to with this slide is that $3.7 trillion that I talked about in total health spending, that really only pays for that tiny little slice called clinical care. And we know that there are a whole lot of other factors that affect overall health. And my argument for fixing, one of my arguments for fixing how we pay for healthcare is that we would have resources left over to address some of those other issues that contribute to overall health if we weren't spending so much on an acute care high-tech system. Other priorities like housing, nutrition, education, income, transportation, and the environment. The other thing that this slide tells us is that we are overspending on high-tech care and underinvesting in things like primary care, just being able to go to the doctor and get your routine healthcare needs met. The graph that represents total health spending for this country, it's 2018, so it says 3.6 trillion. But if you take a look at the insurance piece of this graph, and that means that means public and private insurance, you can see that only about 1/3 of health spending is from the commercial insurance sector, and 2/3 is public health insurance. Medicare, Medicaid, which is funded by both state and federal dollars, plus the VA health system, Department of Defense, Children's Health Insurance Plan, and some other public programs. Also, this graph shows that in addition to private health insurance coverage and public spending, Americans also spend a lot of money for the out-of-pocket costs that we wind up paying in this country. 10% of 3.6 trillion is a lot of money to come out of people's pockets in addition to what we already cover. So commercial health insurance is a smaller piece of the pie than most people realize, and also requires a lot of taxpayer subsidies to work. And in Minnesota, slightly over half of persons covered, now again, this is pre-pandemic, that will have changed, but 52% as a baseline have employer-sponsored coverage. That is lower than generally assumed. And some of these are self-insured, meaning that commercial insurance companies are contracted to manage healthcare benefits for employees of very large employers who can afford to cover the actual expenses. Larger employers not only see tax benefits to providing insurance, but that insurance also helps to lower turnover, which saves them the cost of hiring and training new employees. Small businesses who cannot afford to offer insurance are at a significant disadvantage in recruiting, hiring, and retaining employees. This is really important for the small business sector. 98% of all businesses in Minnesota are small businesses, and they employ about half of the people employed in our state. So it's also a deterrent to expanding their businesses and slows entrepreneurial activity overall. Premiums for policies in that small group and individual market are very high, not to mention the out-of-pocket costs for deductibles, copays, and coinsurance. So on this slide, I have attempted to show the piecemeal way that we try to cover people for healthcare in this country right now. I mentioned some of the ways that are covered in the graph that you just looked at, but many of these are public programs that were put in place to fill the gap in the employment-based private insurance model. So notice, for example, in there, the 1,100 federally financed clinics, which most people don't know a lot about, but those clinics cover millions of low-income individuals and families, the uninsured and underinsured, undocumented persons, the homeless, and the like. These are the organizations trying to keep people out of expensive emergency rooms and also trying to provide decent primary care. But this whole list is our multi-payer system kind of at a glance, and it's not a system at all. It's a patchwork. Only it's a patchwork with big holes in it, and it's costing us a fortune. Okay, why don't we go ahead and take a look at the video that we want to share with you today.
Four years ago, I started an investigation. I wanted to find out why every year at renewal time, my company faces double-digit increases in healthcare premiums. Let's consider healthcare expenditures at MCS, where I am CEO. In 2018, a family plan cost over $27,000 a year. That's $13.50 an hour for one employee with a family. MCS and its employees spent $2.6 million for health care coverage. That's 22% of payroll in 2018. So I took a deep dive into the healthcare insurance industry in the United States, and I didn't like what I found. 155 million Americans receive healthcare coverage through commercial insurance negotiated by their employers. Another 20 million Americans buy commercial insurance on their own. Our healthcare system's reliance on private insurers is the principal reason Americans pay twice as much for healthcare compared to the rest of the world. The result is a huge waste of money and also poor population health. Each year, 600,000 Americans file for personal bankruptcy due to medical bills, most of them having some form of insurance. The system is clearly beyond the economic tipping point. How can we get healthcare on the right track, providing comprehensive benefits to all while at the same time reducing cost? There's a simple solution. It's called Medicare for All. And how do we pay for Medicare for All? The fix is conceptually simple. We adopt Medicare as the insurer for all Americans. We simplify, as other countries have done, the administration of the system by eliminating the expensive middlemen like insurance companies and pharmacy benefit managers that cost us dearly but add little value. We negotiate reasonable prices available internationally for drugs and devices and for medical services under Medicare. We implement a public financing plan that fills in the financial gap created by ending our reliance on insurance companies. To administer MCS's plan, our insurance company takes 17 cents of every premium dollar for overhead. Traditional Medicare takes only 2 cents of each dollar to administer its programs. That's 2 cents versus 17 cents. In addition to their own overhead waste, commercial insurers also cause massive administrative waste at the provider level. Running a hospital in the United States is a bureaucratic nightmare. Many hospitals have one billing person for each bed to handle complex insurance requirements. Doctors and nurses waste hours negotiating with insurers on which treatments are covered and why they are needed. We can save 7 cents of each premium dollar on provider administration with Medicare for All. We all know that pharmaceutical prices in the United States are out of control. We have employees on medications that cost more than their annual salaries. Americans on average pay twice as much for drugs compared to other advanced countries. Medicare for All will establish a regulatory framework to bring down prices to international levels, and that will save 6 cents of each premium dollar we now pay at MCS. U.S. hospitals have regional monopoly pricing power over commercial insurance companies. Medicare does a better job controlling cost by negotiating lower prices for hospital and doctor services. The Commonwealth of Pennsylvania publishes an annual report on hospital economics. It shows that a day in a Pennsylvania hospital under Medicare cost half the amount paid by commercial insurers. Looking at hospital payments across the country, the Congressional Budget Office had similar findings. When we add up all the savings from reducing waste and lowering cost, 41 cents of every MCS premium dollar can be saved with Medicare for All. Our goal is more than just a reduction in cost. The billions of dollars in savings will finance an expansion of coverage to all Americans. As we end our current system's reliance on high insurance premiums, we will use less expensive Medicare payroll deductions to fill the financial gap. Medicare for All will be a tremendous savings for my company and particularly to its hourly employees. For the vast majority of our employees, take-home pay will increase dramatically as premium sharing declines. Overall, MCS's health care expense was 22% of payroll in 2018. That's 22% versus the projected 8.2% as a payroll deduction that Dr. Gerald Friedman projects in his plan to finance Medicare for All. Dr. Gerald Friedman is highly regarded for his economic impact studies on single payer for individual states. He has produced a detailed national model demonstrating how Medicare for All can be publicly financed.
I've been at this for a while, studying the relative efficiency of alternative healthcare finance systems. A great many research institutions have weighed in, and all have concluded that a single-payer system would save money while extending coverage. Just in the last year, Rand Corporation modeled single-payer systems for 2 states, Oregon and New York, and found significant savings even after taking account of the cost of covering the uninsured and improving coverage for the underinsured. While the projected savings vary depending on the assumptions made, even the most conservative studies project that a publicly financed universal health insurance program would save money while providing greater access to needed care. A simple comparison of healthcare spending in the United States with spending in countries with publicly financed systems shows we spend almost twice the average of nations within the Organization of Economic Cooperation and Development. All of these countries spend less but have better health outcomes. Compared with us, the Brits live nearly 3 years longer, the Canadians over 3 years longer, the French 4 years longer, and the Swiss 5 years longer. We waste money at every stage of the healthcare system. Private insurance companies, for example, take in premiums of $1.3 trillion and keep $260 billion, 20% for their own administration and profit. By comparison, Medicare provides traditional benefits of around $500 billion, but only $8 billion is spent on administration, or 2%. It achieves these savings by paying lower managerial salaries, avoiding 8-figure CEO pay, avoiding most marketing expenses, and by not profiting from our health care. The 18 percentage point difference in administrative bloat comes to over $230 billion. We also waste money because it's expensive for providers to process bills for multiple insurance plans. U.S. hospitals and physician offices spend 20% of their revenue on administration, nearly twice as much as do their counterparts in Canada. This is $200 billion wasted billing a fragmented private insurance system, waste that disappears with Medicare for All. Americans pay too much for health care because a few drug companies and massive hospital combinations use monopoly power to drive up prices. If we all paid only what the Veterans Administration pays for drugs, we would save over $200 billion. If we all paid only what Medicare pays for hospital and physician services, then we'd save $400 billion. Monopoly pricing by drug companies and hospital networks account for nearly half of the gap between what we pay for health care and what everyone else in the world pays. So even if we accept the most conservative assumptions, we are still projecting savings almost as great as the current Pentagon budget. Nearly 8% of Americans still do not have health insurance. Universal coverage would add another $70 billion for their additional health care. Many Americans with health insurance find that coverage does not allow them to see doctors when sick or to fill prescriptions because of punitive copays or high deductibles. Using estimates from the Centers for Medicare and Medicaid Statistics, I project that spending may increase by as much as 7.4%, a cost of nearly $200 billion, when we allow people to see doctors when sick or to fill prescriptions. This extra spending should not be regarded as a cost because it means we are providing adequate health care to Americans, lowering the rate of morbidity and mortality and raising well-being. When we say that it is time for a change, the standard response is that it would take intolerable tax increases to fund a public program. There's something fundamentally wrong with this argument, because if Medicare for All is less expensive than the current system, then Americans will be paying less in new taxes than we pay now for private funding. Regardless of how we collect the money, we will be spending less. We are already paying most of what we need for a better healthcare system in Medicare, Medicaid, tax subsidies for employer-provided health insurance, Affordable Care Act exchange subsidies, S-CHIP, and other programs. There are many ways that we could collect the remaining revenue needed for Medicare for All. A moderate plan would pay for Medicare for All by mimicking the way we pay for Social Security now. There would be a payroll tax of 8.2% for incomes above $25,000, a 5% levy against dividend and capital gains income, and premiums to those without labor income and above twice the poverty line. While there are many ways that we can fund Medicare for All, they all share this. If we can pay for the status quo, we can pay for a program that is less expensive. The question is not, can we pay for a more efficient system that would provide better health care? The question is, what is stopping us?
Okay, you just heard Dr. Friedman say that we don't need to come up with a lot of new money to fix this. Two-thirds of health spending is already funded by taxes. The private health insurance is not paying its own way. It is heavily subsidized with taxpayer dollars. What this suggests is that contrary to the claims that we just can't afford a Medicare for All single payer system, we can't afford to keep doing what we're doing right now. Paying for Medicare for All is more a matter of redirecting money than coming up with new sources of financing. Once you realize that we're already putting a lot of taxpayer money into funding healthcare, and add to that the fact that more than 1/3 of every healthcare dollar in the US is spent on non-healthcare activities, we have to question, why would we keep doing it this way? Our multi-payer system imposes an enormous administrative burden on hospitals, clinics, and providers, in addition to the overhead incurred by the third-party payers. And that cost is passed on to all of us. That's $1.2 trillion in total health spending that we could possibly cut in half. Estimates are that we could save about $600 billion in administrative expenses. And what could we do with that extra money? Well, we could cover everyone, we could improve benefits, and we could reduce the cost of our system to patients, families, businesses, and taxpayers. And that's even before we put the one big customer, our government, in charge of negotiating prices on our behalf to reduce the outrageous profiteering built into our market-based system. Attempts to fix how we pay for healthcare are not new. Advocates for a national health plan have been working on this for over 100 years. You'll notice that Medicare for the elderly and disabled and Medicaid for the very poor passed in 1965. That's 55 years ago. And both the Social Security Act of 1935 and the Medicaid Act of 1965 were supposed to be followed by further, more comprehensive legislation. This was very effectively blocked by powerful opposition from the AMA and at the time, around the time Social Security passed, by Southern whites who did not want a system that would desegregate our entire healthcare system, and eventually and ongoing by well-funded lobbyists whose business interests would not be served by a payment system designed to control prices and profits. So failure to pass a national health plan, along with Social Security, allowed the employment-based model of coverage to gain a foothold. Costs continue to rise, however, and it isn't as though we haven't tried to contain costs over the last few decades. In response to rising costs, numerous cost containment strategies have been tried. Some of the things on this list will look familiar to you, going all the way back to the 60s. But moving on to things like HMOs, preferred provider organizations, ISPs, the whole alphabet soup of strategies and schemes that have been tried over 40 plus years, all with promises that if we tried really hard, we could get costs down, and if healthcare were run more like a business, well, that would work. Many of these strategies are based on the flawed assumption that healthcare in this country costs too much because Americans just go to the doctor too often. So they're kind of structured around, let's make healthcare harder to get. Make sure that people have skin in the game, then they'll be better shoppers. That's, of course, the market-based concept. Doctors just order too many tests and medications and procedures. Make them spend more time justifying their orders, and they'll stop over prescribing and costs will come down. We can see that none of these punitive measures really worked because none of it gets at the underlying structural problems of administrative waste and out of control prices. None of this fixes the fact that under our current system, we save money by reducing rationing care and leaving people out. So now that we've tried everything else, how about we go for real reform in how we actually pay for healthcare in this country? As Dr. Friedman said, the question is not how do we pay for it, the question is what's stopping us. And numerous studies confirm the numbers that you just got from Dr. Friedman. There's no sugarcoating this. We have the right policies and we have the economics and we have even public opinion, which favors Medicare for all by at least a small margin when the question is asked correctly, all on our side. But we're up against very powerful, well-financed opposition to disrupting the business model of our for-profit side of healthcare, including the big health systems, and frankly, those who feel that their incomes would be threatened by reform. It will take a massive social movement to overcome big money ideology and fear of change. And just like thousands of people marching in the streets these past few weeks, pushing for change in policing and public services, advocates for real healthcare payment reform believe that we are past the point of accepting measures that would just slap another Band-Aid on our hemorrhage of money currently flowing into the medical industrial complex, thanks to the multi-payer system. The excuse is that it would be just too disruptive to change, that we can't kick 160 million people off their insurance that they like. Well, that notion should be coming under some serious scrutiny right about now. So even before the high unemployment related to the economic collapse and this pandemic, Americans were facing the disruption of losing health insurance anytime they would change jobs, lose a job, get sick and not be able to work, cycle in and out of eligibility. All of this is extremely disruptive. A lot of life issues are extremely disruptive, costly, inefficient, and inequitable, and all are a serious threat to quality and continuity of care, especially if you have a complex health problem. And it also interferes with our ability to have coherent public health and prevention. So perhaps this is as good time as any to point out to people that what they should be afraid of is what we have right now. I ask you to beware of incremental change. Both political parties try to hedge rather than go for real reform, wanting us to believe that we have to accept what is politically feasible. And I especially ask that you beware of candidates and office holders who insist that they believe in universal coverage but will not commit to a state-based or a national health plan. This belief that some kind of additional public insurance layered onto our multi-payer system instead of a single-payer Medicare for all is a more politically feasible middle ground is flawed. I do not question the sincerity of anyone who's working on universal coverage, but it's kind of a catch-all term that stands for a publicly subsidized insurance plan, likely administered by commercial insurance companies or some variation, but kind of intended as a way around eliminating the private insurance market, but covering more people. Be aware that these will eventually result in expensive, high-need patients getting shifted to the public programs with private insurance companies cherry-picking healthier patients They will lack the broader risk pool needed to make a system viable. Cost per patient will inevitably go up. The public program will become too costly and it will fail. People will then conclude that that government thing didn't work. So bottom line, any proposal to add another layer of insurance that fails to eliminate the administrative waste embedded in our multi-payer system will cost more, not less, and will not achieve universal coverage and will not bring down prices. So it's probably time also to acknowledge that the ACA was a good start, but that it's working as designed. It covers more people, but it left the market in place. It doesn't have the tools needed to bring down prices, and we will never control administrative costs until we eliminate the multi-payer system. So one recent example of the hazards of incrementalism right here in our state. If you still think we should keep tinkering around the margins of this massively expensive, inefficient, inequitable healthcare payment system, consider a bill that just passed this session in the Minnesota State Legislature to provide short-term emergency assistance for insulin-dependent diabetics to buy a life-saving drug at a cost they can afford. The Alex Smith Insulin Affordability Act passed on April 15, 2020. It followed 2 years and 9 months of hard work by advocates and legislators. The price of insulin, a drug that's been around for 100 years, has gone up by 1,700% over the last 10 years. Every year, people die because they try to ration or go without insulin. This bill provides a short-term supply under 2 scenarios for a small copay that requires the drug companies to reimburse pharmacies for purchase of insulin. Republicans very reluctantly agreed to this. Advocates were told that the industry would not sue, and the bill passed. Well, the lobbying group for the industry announced just last week, early July, that they are suing to have the law declared unconstitutional, which could tie it up for years. I'm not sure if it can even be implemented as written right now. So in addition to that bill, the proposal for a drug pricing affordability commission, another incremental change to make all life essential drugs affordable, failed this last session. And for a timely example of the level of public investment and the low return on that investment from the highly profitable pharmaceutical industry, consider this announcement about the price by Gilead Sciences for remdesivir, a promising antiviral drug for the treatment of COVID-19. We, the American taxpayers, have a significant financial stake in this drug, from its initial development with the help of government scientists as a possible treatment for hepatitis C, to the $70+ million in government funding for research and clinical funding as a COVID-19 treatment. At least one source has challenged this price and illustrates that prices for drugs in the U.S. are based on making a profit and use of monopoly power, not the public good to set their prices. The manufacturer isn't really even trying to defend the price. Their argument is that it will reduce the cost of hospitalization so that their price is justified. Our healthcare payment system was unsustainable prior to the COVID-19 pandemic, but just consider some of the ways that our system leaves us especially vulnerable to a public health crisis. In addition to our failure to recognize and respond to a pending viral pandemic, which is kind of a whole nother subject of its own, we really have a public health crisis that's creating an economic collapse and no real national strategy for managing and mitigating the disease. Our fragmented system causes people to be afraid to seek care because of cost, And we have a delivery system that emphasizes a factory-style, just-in-time approach to facilities, staffing, and supplies. It does not emphasize readiness. So this pandemic has worsened a system that was already failing persons of color and the millions of us who are lower income, uninsured, or underinsured. And specifically, how would single-payer Medicare for All improve our response to a public health crisis like COVID-19? Here are some examples. Broader access would improve underlying baseline health. Fewer people would experience the financial impact of high costs. We can offer actual care that would reduce or eliminate the wasteful bureaucracy in our multi-payer system. The legislation already written calls for and funds a more efficient public health services, and healthcare as a service versus a business model encourages readiness for an event such as the one we're in the middle of right now. Universal coverage could reduce racial, economic, and geographic disparities, and global budgeting and workforce development would address funding and staffing for underserved populations in both rural and urban areas. So what is the answer? We've already learned that we can actually pay for it. And given all this, what should our approach be? Well, interestingly, our first Republican president said that the legitimate object of government is to do for a community of people whatever they need to have done that they can't do for themselves in their separate capacities. And that includes things like infrastructure, schools, charities. Combining our resources is just much more efficient and effective. I would argue that we've already decided that it works well to do a lot of things together as a society. So taking a look at this list, none of us could afford to pay for all of these services separately, and yet we count on them to be there. We fund them with our system of taxation. If we looked at healthcare in the same way we look at public schools, infrastructure, police and fire protection, disaster relief, and a host of other services, we could design a system to fund healthcare delivery that actually meets the needs of individuals, families, and businesses instead of the demands of a market. I'll just mention, because you hear terminology that might be a little bit confusing. The term single payer or Medicare for All are very familiar, but I also talked about the fact that we could build a state-based health plan. So even though more people are familiar with Medicare for All, Minnesota and several other states are on a dual track of legislation toward a national health plan. A number of states are working on state-based health plans, including ours. Bills have been introduced for a Minnesota health plan in both the state House and Senate, and for a national health plan in both houses of Congress. So while it would be more efficient in the long run to pass a national health plan, it's possible that states will have to show the way, and we could start right here in Minnesota. Well, I'll stop here and take some questions, if you're ready.
I just want to remind people that if you do have a question, please type it into the Q&A box. It's at the bottom of your screen. You just click on Q&A and there'll be a box that opens up and you can type your question in there. So far we've had a few questions about how to access some of the information in this presentation. So number one, we will be sending out the slides. We'll email those out to all registrants. So even if you're if you registered and you didn't attend, you'll still get a copy of these slides. Someone has asked if we could put some of this on our website. We can certainly take a look into that and see where an appropriate place might be to put a presentation deck like this. Another question was about the video itself. How do we get everyone to watch it?
Right.
Well, So it is free. It's free to watch on the Fix It healthcare website, and they have additional videos to watch there as well. They have a set of 3 short videos, which is what we're using for our webinar series, but they also have a couple long form videos as well that are also very, very good. I think they're about 45 minutes or so long. But you will be getting an email, post-webinar email. So you get actually 2 emails. One will be a post-webinar email that lists resources and a link. There'll be a link to the website Fix It Healthcare. And then, like I said, you'll be getting a second email that has these slides. So I hope that takes care of those questions. And then I'll go to some of the topics, more on the presentation topic. One question we had was, I'm not sure, I think maybe this person is referring to supplemental insurance with Medicare. Would we still have to include Blue Cross to cover some of our expenses?
No. Good question. And the answer is no. All the legislation that we support and that is currently introduced at the state and federal levels are designed to cover all medically necessary care. There would be no need to purchase any additional insurance. In fact, commercial insurance companies will be prohibited from attempting to sell insurance for anything that's already a covered benefit. And that's why you hear the angst when somebody says, you might call it the accusation that, you know, you're going to eliminate all commercial insurance. Well, that's because we really don't need it. That should not be seen as a threat. That's actually a good thing. That's the only way we're going to reduce our administrative expenses and redirect that money. So there might be a small slice of people who want services that are not medically necessary, purely cosmetic surgery, but that market would be very small. And we also do not want a 2-tiered system. We do not want any system where people are allowed to purchase something that puts them at the front of the line. So these bills are written specifically to prohibit any sort of gaming the system or gaining some kind of advantage because you've purchased something better. I hope that answers that question. I really like our state-based proposal, Minnesota Health Plan, and the HR 1384, which is the Congressional House bill. Both of them very strongly emphasize equity. And I wanted, you know, our whole purpose in creating this series, and especially showing this particular video, how Medicare for All, how do we pay for it, is the question that people get worried about and hung up on the most. And I hope that you can start being assured that there's enough to go around. It's just a matter of redistributing and reallocating and fixing how we spend our money.
Exactly. We already spend enough to cover everybody. It's just going to into the wrong hands.
That's right.
Okay, next question. Would there be pushback from businesses that are not currently offering health insurance to some or all of their employees if they suddenly have to pay an additional 8.2% payroll tax? Has any incentive been proposed to mitigate this?
What we know from working with a couple of particularly small business associations here in Minnesota, the Main Street Alliance and the Metro IBA, or Independent Business Association, is that they would be better served to have a universal system like this where they could just contribute a certain amount of payroll to pay for it, because they're strapped because they can't afford their own insurance for their own families. So everyone we've talked to would consider it an advantage and money well spent. to be able to cover not only themselves and their families, and then know that their employees are covered. So information we have so far, and of course you heard Richard Master when he introduced this video. His entire mission in creating this Fix It series was to fix what he learned of as the owner of a, I'd say, medium-sized business in Pennsylvania, that his costs were going up every year unpredictably and uncontrollably. So I'm fairly confident that most employers would find this to their advantage, with the possible exception of really large employers who kind of levy their size and power to use the taxpayer subsidies to their advantage. But it's a smaller segment of the population, and we're gonna, or of our society, and we're gonna have to overcome that eventually with convincing the majority of us that this is to our advantage.
Okay, great. We've had a couple questions about the effect on current employees in the health insurance industry. How do we, what is the approach for assisting them when they lose their jobs in the health insurance industry?
Well, that's a question that comes up often. It's a good question. It was a little easier to answer before the current level of unemployment, but I'll tell you what we know from at least before the current levels of unemployment hit us. Both proposals at the state and federal levels, first of all, call for a 2-year transition period, so that and support for people who currently work for insurance companies and hospitals in their billing departments. In Minnesota, at the time that a study was done, that about 42,800 people work on the administrative side of healthcare, which was at the time about 1/3 of the number of persons who currently change jobs every month in Minnesota. So easily absorbed in our workforce. We also believe that many jobs would be created as a result of removing the burden of the cost of healthcare coverage from employers. You know, so obviously because of the unemployment situation that we're in, every one of these measures will be, you know, require more thought and more emphasis on workforce support and management. The bills also include retraining. We also know that we're going to need more healthcare givers, you know, healthcare providers, and we need to plan for our needs going forward. So I still think it's very reasonable to suggest that we can absorb the shift in employment status into our new system.
Let's see. Will Medicare for All eliminate prior authorizations?
In general, it'll greatly reduce it. I guess I would almost defer to practicing physicians to know how often they get challenged by Medicare. But my understanding is that there are very few challenges to treatment plans and medications that come from Medicare and Medicaid. Most of those barriers are imposed by the commercial insurance companies. And the reason that Medicare recipients wind up kind of on the wrong side of this prior authorization issue is that if they have chosen a Medicare Advantage plan, then there's a commercial insurance company in between you and your Medicare benefits. So just traditional Medicare, which by the way will be improved, the benefits that will be improved. So don't even think of Medicare in its current form. Medicare will be, the Medicare for All term will be improved to include all necessary care, which includes dental care, long-term care, vision, hearing, the things that people typically buy a supplemental policy for now. None of that would be needed. And then Medicare sets standard, evidence-based treatment protocols and formularies, and it's easy to understand what is available because it's standardized. You don't have to figure out for each different insurance plan or each different program what you can order.
Okay, there's a couple of questions related to how do we get a politician or candidate like Joe Biden to change his stance on Medicare for All?
Massive public pressure, which is why we exist, is to create the demand. I mean, I realize the presumptive nominee for the Democrats is pretty dug in supporting the Patient Protection and Affordable Care Act because of course, his involvement with passing that bill in 2010. I can kind of understand that. I'm not sure what Vice President Joe Biden and his campaign do not understand about the economics of our current system, but we're going to have to work on it. And we totally exist to create that grassroots pressure to push up and demand change. I'm very interested in listening to some of the speeches and press conferences so far. We've got a lot of politicians calling for bold action on the environment and infrastructure and gun violence prevention. And then when it comes to healthcare, we want to sort of stick with, tinkering around the margins. So we're going to have to create that pressure for bold action on fixing how we pay for healthcare as well. That's where y'all come in. We're going to talk a little bit about that.
Could you address how Medicare for All would affect physician compensation?
Yeah, and I want to for sure refer you to the specific section in HR 1384, which, by the way, if you've never read a piece of legislation, you might consider trying it. Go to congress.gov and pull up HR 1384. The entire bill has been turned into an actual description of how this legislation would work. But physician and provider compensation is covered in the section on budgeting. And kind of in a nutshell, as I understand it, physician and provider compensation, which is private practice, includes therapists and counselors and other nurse practitioners and PAs and so on. It looks like they would have a choice of being an institutional employee, as many are right now, or working on a fee-for-service basis. What we understand about physician compensation as well from other countries, especially our neighbors to the north in Canada, are that highly paid specialists might do a little less well, people who are really on the high end of the income scale here in our country, in the US. But primary care providers, family doctors, pediatricians, mental health providers would do better, would do somewhat better, which ought to be good news, I think, overall.
Okay, so this question is about employer paid premiums. Being able to be deducted as a business expense, would this also be the case for Medicare for All?
The payment model that Dr. Friedman talked about would be a payroll tax. So similar to Social Security and Medicare, right now, the employer pays half and the employee pays half, correct? So I don't think that's deductible as an operating expense, but I don't exactly know that answer, and I might need to look it up. Is a payroll tax deductible as an operating expense? But it wouldn't function like an insurance premium that they get to take a tax subsidy for. This would be a contribution to a national health plan, similar to what they contribute now to a national pension plan, which is Social Security, which I think is a really simple and really nice way of doing it.
Is it true that businesses would not have to pay fees like worker compensation, liability, insurance, etc., under Medicare for All?
Well, as I understand it, in reading the Minnesota Health Plan, that is spelled out by Dr. Marty, Senator Marty. I keep promoting it to MD. No, our state-based health plan, and I'm thinking likely our national health plan as well. Well, workers' compensation is state-based. So no, that would all be covered by our health fund.
And can you address any other state-based efforts on universal health care? Specifically, I think Vermont had an effort, and what Massachusetts did as well with Romney Care.
Well, Romney Care is really the same thing as the ACA. They just created some legislation that would expand coverage in and mandate coverage in Massachusetts. So think of Massachusetts and Romney Care as very similar to the ACA, which left a market-based system in place, a multi-payer system. The question about Vermont comes up a lot. Apparently, the Vermont proposal was not truly a single-payer proposal. And even though a bill did pass the legislature, and this is probably more than 10 years ago already, Vermont, first of all, has only a population of 600,000. And two of the biggest employers in Vermont refused to participate. So their governor decided that it would not be financially feasible for them to proceed. There are 17 states in the country right now, 17 plus maybe. It's called the One Payer State organization, each working on a state-based health plan. And we're one of those 17. Now, creating your own state-based plan requires national legislation that would allow the states to create a state-based health plan, which then allows you to access the federal half of Medicaid funds, Social Security funds, and some other funds that we would need to make it work. So you can see that even though it would be great to get something done, there's a couple of barriers right now, and it would be more efficient to do a national health plan, which kind of explains the dual track. If we can't get the Congress to do it, then it might be to our advantage to work on it here in Minnesota. The other problem right now is you may all recall or realize 21 Republican states attorney generals have sued to have the ACA declared unconstitutional entirely, and it could literally be gone if the Supreme Court ruled that. Now, we just learned that they've already done all of their rulings for this year, and it's being pushed off till next year, which I thought was an interesting decision, kind of leaving people hanging. Depends on who wins the 2020 election. That entire law is in the balance.
Couple more questions, then we'll be done. How does Medicare for All address racial disparities?
Oh, there are several sections in the HR 1384, especially specifically designed to target funding to underserved areas and communities, and specifically requires attention paid to minority groups and reducing disparities and funds for that. And also, and they define underserved areas as rural areas and some high density underserved urban areas. So I like the possibilities of meaningfully addressing our racial, income, gender, and other health disparities if we pursue and pass HR 1384. I really encourage people to read it because there are a lot of provisions for special programs and requirements to make progress on these disparities that have plagued us for decades.
And in addition, people wouldn't be holding back on health care because of cost. So they would go to the doctor more frequently and have their needs met.
Think of Medicare for All, or a national health plan, let's say, or state-based health plan, national health plan. Think of it as a system that is pre-funded. It's not free, but pre-funded and free at the point of care. The entire goal is to cover everybody, and that all means all, and then eliminate the barriers of cost when you need to seek care.
Would Medicare for All eliminate the need for having health care insurance on automobile policies?
Very likely, yes. That's a really good question. That's the vision, for sure at the state level, and probably the vision at the federal level as well. Yep.
And here's our last one. Can you comment on the statement in the video that said 41 cents of every dollar is spent on non-medical care? This is a higher amount than I have heard in the past.
So the number we've been using is that 34%, or 34 cents out of every dollar is spent on administrative costs associated with handling the hundreds of different policies and programs. I may need to check on the 41 cents unless they're talking about capital expenses, building expenses, not just operating expenses of keeping the doors open and paying your staff.
We can follow that up in the email as well.
That's a good
answer to that. Okay, let's move on to our call to action.
Okay. All right. So I hope by now you are asking what you can do to help. Well, it's all about numbers and intensity. As you can see, every social movement requires a lot of grassroots numbers and intensity. So even though the cost of healthcare is a huge concern for a majority of Americans, and you'd think there'd be an enormous sense of urgency to fix this, and a top issue for voters, real reform is not going to happen without a lot of involvement from the public. Building a movement for change means that we have to educate and engage all of us, organize and build our base of support, and pass and implement legislation. We have to create the demand for change, and we have to make it clear that the status quo is no longer politically feasible or acceptable. As you can see, we've got on this list a lot of opportunities for volunteers. Some are more easily done in person. We've been a little bit hampered because of the inability to do in-person events, but we are adapting to the need for digital communication, and our education series is one of those moves. And of course, a top priority for the next few months is going to be the upcoming election. Talking to voters, supporting candidates who are with us on this issue, and then holding legislators and members of Congress accountable for progress. So our purpose with this webinar has been to give you the information you need to have good conversations with voters and to be a resource to candidates and office holders. Keep in mind that not every candidate or a member of a legislature or Congress is all that versed in health policy. We can be the honest brokers for this information. Even with the legislation already introduced, we have to have a legislature or a Congress friendly to reform in order to get hearings. The simple basic fact to remember is that the party in the majority sets the agenda. So I would suggest for sure to make a pledge to learn what you need to know to feel confident in having conversations with friends, family, neighbors, voters, candidates, and elected officials. Here's some examples of where you can go for more information. If you're not on our email list already, if you responded to this you got an invitation from somebody, or you signed up on Facebook, please go to our website and put your contact information in the box where it says join us. Like us on Facebook, Share the Fix-It videos with others. Somebody already asked where they can get the videos. That's the website right there. But if you just Google Fix-It, it pops right up with Healthcare at the Tipping Point, and then you can get into the site and look at all the videos, and they are excellent. I especially recommend reading Healing Healthcare by Senator John Marty, explaining the Minnesota Health Plan proposal. It's available on our website. It's also available on his website, and you can buy a paper copy. It really helps you understand not only the proposal, the health policy behind it, and what a transition plan would look like. Share events like this one today with others. Invite others to join us. That's how we grow. That's how we win. And then also thought I would share with you a list of some of other organizations working on a national health plan. National Nurses United has an excellent resource with frequently asked questions, huge answer to anything you want to ask. You can also sign up for webinars and updates with them. Visit the website for Physicians for a National Health Program, which is a wealth of information. I get most of my stuff on healthcare economics from Physicians for a National Health Program. And actually anybody can sign up to be a member of that organization as well. It's specifically started to engage physicians and the provider community, but it's open. Take a look at the Kitchen Table campaign with a different theme for each month and some actions you can take with them. And you'll notice that there's the Business Initiative for Health Policy. One of the members for the Business Initiative for Health Policy is Patriotic Millionaires. I find that very interesting. Also, labor is involved. If you get the question or the comment that, well, you know, labor unions have negotiated for all those great health care benefits and they can't afford to give it up now, I would challenge that strongly. We've got a number of labor unions who are strongly supportive of a single payer Medicare for all approach because they've learned that they're expending an awful lot of bargaining power just trying to hold on to what they have, and it's increasingly expensive for their members. And I want to kind of, we're close to the end, and I want to say that I can easily make the economic case for reforming how we pay for healthcare. That's what today was all about. But in the end, it's also a justice issue that crosses racial, economic, gender, and political lines. Martin Luther King Jr., in his 1963 letter from Birmingham jail, wrote that injustice anywhere is a threat to justice everywhere. We are truly all in this together. And one last thing before we end. Unemployment is reaching levels not seen since the Great Depression. There are two emergency proposals that have been introduced in the Congress that could actually become an eventual path toward a Medicare for all. And they're far superior to the proposals that are, being made right now for how to get people covered short term. Get out your phone and take a picture of this slide, and it'll also be in the slide set that you receive in your email. But if you want to do this right now today, we really strongly support expanding insurance to people who suddenly lost it in ways that do not just pour more money into the commercial insurance industry. As soon as you leave this meeting, you can go to the phone and call your representative and both of your senators and ask them to vote for the Medicare Crisis Program, which would cover any U.S. resident eligible for unemployment insurance, and then ask them to vote for the Healthcare Emergency Guarantee Act, which would provide coverage for anyone currently uninsured. That number that I gave you of uninsured prior to the pandemic, and cover out-of-pocket expenses for people who have health insurance. So that would be my ask for something that you can do today. I hope that this has been helpful for you to answer that big question of, okay, I agree that everyone should have something, but how are you going to pay for it? We can and we must. This is my contact information. And I am always available by phone or by email for questions. And just want to thank you for joining us today.
Thank you, Anne. And I would like to remind people that if you have a group who would be interested in a presentation on this topic, to please contact Anne or us at info@hca-mn.org. We're happy to do presentations to groups. It's especially easy now with this online technology, and we can create a Zoom presentation for your group, any group that you may want to include. So thank you again, and then I'll remind you, our next webinar is Wednesday, August 5th at noon, and the topic is Canadian Healthcare Debunking the Myths. So if you are on our email list, you will get a notification of that event. So that's another reason to join our email list if you haven't. And it will also be, and it will be on Facebook. So if you're on Facebook, please like our Facebook page, as well as PNHP Minnesota's Facebook page. Join their email list. Then you'll have all the latest and greatest information on upcoming events. Again, thank you for joining us, and we hope you'll get out there and we'll really make this happen.